Welcome everybody to another Kansas State Veterinary Diagnostic Laboratory webinar. Looks like we've got a lot of attendees today. Thank you to all of you that have participated before. We appreciate your loyalty. And for those of you that are new today, join us. We really appreciate both groups for taking your time out during the day to spend some time with us. A little bit of bookkeeping for those that have just joined us for the first time is that number one, if you stay with us for the whole time, 2 to 3 weeks after the webinar, we will send you via email a certificate where we'll give you 1 hour of continuing education. This webinar is recorded and it'll be planted on the KSU CVM CE website, and there'll be a little quiz to go with it. If somebody watches that recorded program and takes the quiz, they will also receive 1 hour of free CE. We'll also plant the recording on our KSVDL YouTube channel, and anybody can watch it. Unfortunately, if you watch it there, you will not receive 1 hour of CE. We highly recommend that you subscribe to our YouTube channel. We add videos pretty often on there, and if you subscribe, it'll ping you to let you know that we added something that we hope is of interest to you as practitioners. The other thing is this is meant to be 1 hour long. It's going to be about 40 to 45 minutes of a presentation, and the rest will be questions. If you have questions, just look at the top of of the teams there and enter your questions in the Q&A. And if you enter it in the Q&A, nobody else will see the questions. It'll just come directly to us. So please use that for us. And if you have problems, if you have technical issues, we've got a whole group of technical people here that will help you via online. So enter that either in the chat or the Q&A. The other thing is that you'll be asked to complete a very short survey after this webinar, and we really need your feedback. We'd like to know what we're doing right. We'd also like to hear of some things you think that we could do better. We want to continue to do these webinars, but we want to continue to improve the quality for you as veterinarians out there. The other thing on the survey is we ask for topics. So give us an idea of what topics, what animal species, diseases, diagnostics that you would like us to present in these short webinars. So with that, it's my great pleasure to introduce our specialist for today, Dr. Hatem Kitana. He just joined KSVDL. He's the section head for our microbiology, bacteriology, mycology section. A lot of you have already talked to him on the phone. He loves to talk to practitioners. His contact information will be the very last slide. So if we don't get to your question, or if you have questions down the road, it has anything to do with microbiology, he use that contact information. He loves to talk to practitioners. So please use his knowledge. Hatem, he earned his degree from South Valley University in Egypt in 2009. He then completed a PhD in microbiology and immunology from University of Nebraska, which we won't hold that against him. And that was in 2018, followed by a clinical microbiology residency at Missouri, which again, that's okay, in 2021. He is a diplomate of the American College of Veterinary Microbiologists, and he's board certified in bacteriology, mycology, and immunology. So he brings a lot of knowledge base and a lot of experience with him. So welcome, Dr. Kitana, and I'll turn it over to you.
Well, thank you, Dr. Hanselchek, for the introduction and for the nice words. I really appreciate it. Hello, everyone. Thank you for joining us this afternoon, and my name is Hatem Kitana, and I would be very happy to discuss some aspects of the susceptibility results that you received from K-State VDL with you this afternoon, and we walk together through the process of understanding susceptibility profiles and how we can actually use this data in proper selection of antibiotics for treatment. So I would like to get started with a little bit of a background and a little bit of basic questions. Is why do we actually do susceptibility testing? Why we request it? Why we perform it in the laboratory? And the short answer for this would be because bacteria are smart they learn very quickly, they adapt to the environment they live in, and they develop antimicrobial resistance. And that's what we know as antimicrobial resistance, or AMR. And this is one of the most important causes, if not the most important cause of treatment failures that we face in our profession and in medicine in general. So for us as veterinarians and as clinicians, when we deal with a case and we are in the process of choosing an antimicrobial for treatment for a specific situation, there are certain factors and criteria that we think about when we make this decision, including, of course, the safety of this antimicrobial to our patient, the route and ease of administration. Does this antimicrobial get to the infection site and target this bacteria and actually control it? And of course, the cost, how affordable this treatment to our clients. However, all these factors, they come together and they serve the main goal, which is, for our patients to recover, for them feeling better, that we target this, bacterial pathogen and get rid of it through a very optimal and achievable in vivo concentration of this drug that be able to inhibit this bacteria. And although most of our discussion today is going to be about bacteria, the basic knowledge and the broad spectrum of what we're going to talk about is very applicable to fungi as well. So I think the second question would come to mind is, when should we run antimicrobial susceptibility testing, right? Do we run antimicrobial susceptibility testing on all isolates that we recover from a clinical specimen? And the answer to that would be no, because some of those bacterial pathogens or fungal isolates that we recover from there are not going to be clinically relevant. They are not major players that are playing a role in this disease condition. And then ideally, we run susceptibility testing on those etiological agents or bacterial isolates that have an unpredictable response to antibiotics. Some, to just name some here, members of family Enterobacteriaceae, right? E. coli and its cousins, Salmonella, Proteus, Klebsiella, and others. Staphylococcus species, mainly hemolytic staph, they tend to be more pathogenic. Pseudomonas species, especially Pseudomonas aeruginosa and others. Enterococcus species, those are ones that we tend to see different, or we tend to see variability for their response to antibiotics. And the other reason, or the other scenario when we should run susceptibility testing is, or we recommend running susceptibility testing, is when the outcome for treatment is not achieved, right? Whether an initial antimicrobial susceptibility testing has been run or not, the animal is not improving, and then we need to think about an approach to this. And some of the reason that would happen could be due to improper selection of an antibiotic, or improper use of it, whether through the dose or the frequency was not the correct thing, change in the sensitivity pattern of this bacterial organism that we're dealing with, whether they acquire antimicrobial resistance from the environment they live in, or they actually mutate and become more pathogenic. So to shift gears a little bit here, and we're going to talk a little bit about some of the definitions that are important for us when we discuss antimicrobial susceptibility. First is the minimum inhibitory concentration, right? Some of these terminology our veterinarians and our audience are very familiar with. The first one is the MIC, right? This is the lowest concentration of the antibiotic that is required to inhibit the in vitro growth of bacteria. If you look into the graph here, we see here in the far left, this is the tube with just a pure bacterial culture, no antibiotic added to it, and we see the turbidity in purple there. As we slowly adding the antibiotic to the series of the tubes following to that, so from 0.25 micrograms, 0.5, 1, 2, 4, and then 8, we see a fading in this turbidity until this turbidity actually goes away and there is no clear turbidity or bacterial growth by 2 microgram per mil. And this 2 microgram per mil would be here our MIC or minimum inhibitory concentration. Now at this dilution or at this specific concentration here, the antibiotic is a bacteriostatic, right? So the bacteria is not visible to us, there is no visible growth, but that doesn't mean that all the bacteria are dead. And that's why, you know, we have the course of treatment over few days or few weeks, so to continue inhibiting this bacterial population and control the infection over time. And then minimum bactericidal concentration or MBC, and this is the lowest concentration of drug that inhibit or that totally eliminate the bacterial growth, and so that the bacteria is not recovered again by culture. And for bacteriostatic agents, usually there is a gap between the MIC and the MBC, usually like few concentrations gap between them, while for bactericidal antibiotics like beta-lactams or aminoglycosides, then the MIC and the MBC are very close to each other, probably one concentration difference. And then we have the mutant prevention concentration or the MPC, and this is the amount of the drug or the concentration of the drug that is required to inhibit the development of mutants, right? This is become very important when we're dealing with immunocompromised patients. We want to stay above the MIC as long as we can to protect those patients from any possible mutant development. And the MPC is usually around 10x of the MIC. So if the MIC is 1 microgram for a certain antibiotic is 1 microgram per mil, then the MPC for it, the minimum or the mutant prevention concentration would be 10 micrograms per mil. This is not usually achievable, especially like, you know, as we increase the dose of the drug, we increase the concentration, the serum concentration of this drug in the animal body or the target tissue, and at some point there is a peak of this serum concentration. So, you know, it doesn't matter how much we go higher there. Of course, there is a cap for the approved doses, right? Because after that, then there might be a side effect or a toxic effect, and then we can't go over this target serum concentration. So it's not achievable, the MPC for certain drugs. However, we thrive to get to it, especially for immunocompromised patients. And then becomes, you know, this important point about the breakpoints, right? You know, this is the important question that we always get in the lab. What are these breakpoints? Why are they important? And how they play a role in the interpretation or in determination of the bacterial organism interpretation. These values or these clinically actually essential values are a defined antibiotics concentration or a zone of diameter inhibition depending on the way we measure the susceptibility, and we use these values to determine if a microorganism is going to be susceptible, resistant, or somewhere in between for a given antibiotic, right? And that's, you know, we have the susceptible, intermediate, or susceptible dose dependent, or resistant. So what these definitions mean? Susceptible means that the organism is inhibited by the achievable concentration of the antibiotic in vivo, in the blood or in the target tissue after the approved dose, after the dose that is labeled and after the dose that we are familiar with. Then susceptible dose dependent, this has become, you know, now a little bit more specific. It's very similar definition to the susceptible, except here we have multiple approved doses that are available for us, and this become, you know, particularly important for us for concentration dependent antibiotics, right? When we increase the concentration or we increase the dose of the antibiotic, the serum concentration or the target tissue concentration of this antibiotic increase, and then based upon that we determine, you know, if the organism will be susceptible or not. And then we have intermediate. Intermediate, that means that the organism can be inhibited or only inhibited by the maximum achievable concentration of the drug after the approved dose has been given. So here we are actually, stretching the lines. We're getting into the maximum dose that is approved, right? We're approaching side effects or toxicity here, because we don't know if we actually give more than this approved dose, or this dose has been tried before, and we have clinical data for it, what will be the adverse effects or the toxicity effect on our patients. And here this actually also makes us think that if we give a dose lower than this dose, then there is a good chance for development of mutants. That's why intermediate is usually very tricky when it comes to selection of antimicrobials for treatment. And then of course we have the resistance, which means that the antibiotic is resistant or not inhibited by the achievable concentration of the antibiotic in the drug, in the blood or in the tissues after the approved dose. So the dose is given, we reach a certain concentration into the body in the target tissue. However, this specific organism will not be affected by this concentration. All right, so the question then becomes where these breakpoints are coming from, why they are important and how they are derived. And let me tell you that this is not a very straightforward process. It requires a lot of data. There is a lot of work and a lot of aggregation of data that goes into these breakpoints: pharmacological data, microbiological data, in vitro data, patients' data, so in vivo data as well, and lots of regulatory considerations. All these aspects, all these pieces of information are being examined and carefully revised by national and international committees before even these breakpoints make it to a publication and become available for us. So for example, here for us in the United States, these breakpoints are reviewed either by the FDA or the CLSI, the Clinical Laboratory Standard Institute, the Center of Drug Evaluation and Research, and in Europe by the European Committee of Antimicrobial Susceptibility Testing. So these are a lot of experts that they get together and they bring this information together, in vitro data, in vivo data, and of course regulatory data as well, before these breakpoints get into publication. Once these are approved and are out there, then we become readily available and accessible to us in a document, just like you see here in this document on the screen. This is the most recent CLSI guidelines for antimicrobial susceptibility pattern for bacteria that are recovered from animal sources, that was just published in January, February this year. And once these are published, they also make their way to into softwares where they actually get programmed into our instruments to allow for automated interpretation. We know the breakpoints for susceptibility, for breakpoints for intermediate, for resistance, and then we get automated interpretation for that. However, it's very important here to point out that the breakpoints are not fixed values. They always subject to review, subject to review. They are subject to evaluation once more data become available to us, right? That's why we need to revise them and constantly in a regular way. And some of the reasons that actually these breakpoints get reviewed is if a laboratory technique get optimized, which will affect the breakpoint, then we need to look into these breakpoints again. If a new resistant mechanism or a novel resistance mechanism has been identified in a certain group of bacteria and affect the breakpoints to some antimicrobials. If a new clinical data come out and show there is a poor correlation between a certain breakpoint and the treatment outcome, and the clinical data become very important, because this is one of the most important factors that we use to determine a breakpoint, the treatment success or failure. So there is factors that come together here, make those breakpoints, in the process of revision and into getting them into updating every now and then. So all these aspects, all these data that come together, they are contingent, or they are serve these breakpoints they are coming together as a contributing factors from 4 different sources. So we look for, of course, the animal species, the site of the infection where this bacterial organism is, the species of the bacteria, and the antimicrobial agent that we are interested to test it against this bacteria. So for our example here, we have, our patient is a dog with a UTI, so we have a urine sample, and we isolated an E. coli from this urine sample, and we want to test the effect of enrofloxacin on this E. coli. Now, if we have data, in vitro data, right, and in vivo data, clinical data as well, from all those 4 contributing factors, those all 4 factors, then we will get an interpretation, whether it is susceptible, intermediate, susceptible dose dependent, or resistant. If data is missing for one or more of these factors, we get the NI, or no interpretation, right? So interpretation basically means, and because this is we get this in the susceptibility reports for very much most of the bacterial organisms against several antimicrobials. No interpretations mean here that there is no clinical evidence that correlates the in vitro data with a clinical outcome. We lack the clinical data. We lack this in vivo data, the clinical trials. Or it could be the NI means also that there is no well-established microbiological techniques that test this bug-drug combination, right? We are lacking the consistency, and we are lacking the very well-established in vitro assays. So either we're lacking some in vivo data, or we're lacking in vitro data, and that's why we get to this no interpretation. However, it becomes very important here as well to highlight that NI does not necessarily always mean the antimicrobial will not be usable or will not be effective, right? It just basically means that we don't have the data that we can paste upon it, make this claim or make the interpretation or the judgment that this bacteria will be susceptible or having intermediate susceptibility or resistant to a specific antimicrobial from, that were recovered from a certain site of infection in a certain animal species. All right. So then the questions become how we do actually determine susceptibilities, right? Then the susceptibilities, we are always determine them by testing the response of the bacterial isolate to the antimicrobial exposure, right? And there are 3 common ways that labs are used. Historically, the most known method was the disc-diffusion or the Kirby-Bauer disc-diffusion method. And this here involves, as you see in the screen, inoculation of an agar plate with a bacterial suspension, and then we apply a disc on it. This disc is, loaded or impregnated with a defined concentration of antibiotic, right? Single antibiotic. And then we incubate this plate overnight for 18 to 24 hours. Next day, we measure the zone of inhibition of the bacterial growth by a means of a caliper or a ruler. And then we compare this zone of inhibition to the interpretation guidelines, and then make our judgment. So as you can see here, one disc basically mean one antibiotic means one concentration of the antibiotic, right? So here, this is only provide us with interpretive data, whether this bacteria is susceptible or intermediate or resistant to a certain antibiotic, but it doesn't provide us with MIC, which is the minimum inhibitory concentration that we are interested in. And, the example for that, let's go back to the example about the E. coli and the enrofloxacin, right? We are, isolated this E. coli, we grew it on the agar plate. We want to test the effect of a 30 microgram of enrofloxacin on this E. coli. So we put the disc on the plate, we incubate. On the next day, we measure the zone of inhibition. We found when we compare this zone of inhibition to the interpretive guidelines that this E. coli is susceptible to 30 microgram of enrofloxacin. But that doesn't mean that this E. coli is not sensitive to 29 micrograms. It doesn't mean that this E. coli is not sensitive to 1 microgram of enrofloxacin. We don't have this MIC there, right? We have a fixed value there. So it's a very easy technique, right? Very, like I said, a cheap technique as well. Very good screening tool that labs use. However, it has a lot of limitations, including, like I mentioned, lack of MIC. We can't run it on all available organisms for us, so it's not very optimal for anaerobic bacteria or for slow-growing bacteria. And also, like when we place those discs on the agar plate, we want to make sure they are not close to each other or close to the edge of the plate, so we don't interfere with the zone of inhibition. Of course, after that as well is the time consumption with measuring all these zone of inhibitions as well. Moving with the second known method for determining susceptibility, which is the E-test or the epsilometer method, which is very similar to the disc diffusion in the sense that it is one antibiotic per plastic strip, but it's also different than the disc diffusion that it provides us with an MIC. So the way it works, it is a plastic strip that is also impregnated or loaded with a gradient of the antibiotic. You see here in the top picture, this is like the one side of the strip has the scale, this gradient of the antibiotic, and the other side has the antibiotic gradient in it. We use the same technique for the disc diffusion here as well with the E-test. We grow the bacteria on from this bacterial suspension on agar plate, place the strip, the E-test strip on the plate, incubate overnight, and the next day we measure the MIC. And the measuring of the MIC here is going to be the line here, the intersection line between the lower part of the ellipse and the plastic strip. That is the lowest concentration of this drug that inhibited the bacterial growth there. Useful information, provide us with MIC, but again, the limitation will become as we only use one drug per strip. And then we have the most common used method right now in diagnostic laboratories, and the one that we used routinely here at K-State VDL as well, which is the Broth microdilution method, right? These are microtiter plates or 96 well plate that are preloaded or they are pre-coated with different antibiotics and different concentration of each antibiotic that are diluted into these wells. Right, and then as you see here in this graph, for the bacteria, for the antibiotic compound A, the lowest concentration will be at A11, and then as we go this way, as we go left here, the concentration will increase, and it's usually twofold increase in the antibiotic concentration. So if this is 1 microgram per mil, this is going to be 2 microgram per mil, 4 microgram per mil, 8, 16, etc., etc. And then the MIC will be, of course, the first well with there is no bacterial growth, there is no visible bacterial growth, and this is what you see here in this low panel, and the bottom panel here. See 4 different concentrations of a drug in these 4 wells. 0.5 microgram per mil, 1, 2, and 4. There was a bacterial growth in the first 3 concentrations, which is determined by this nice bacterial billet at the bottom of the well. Some of the bacteria, they don't actually form billet, but rather make turbidity like Pseudomonas species. But here, the bottom line there, the first well, when we don't see visible bacterial growth, this is our MIC. So for that specific drug, the MIC for that specific bacteria is 4 microgram per mil. Now, I wanted also to highlight this row here at row number, this column here, column 12. This is what we call the gross control column, or the gross control well. And these wells are not pre-coated with antibiotics. We use them as internal control for this assay. So when we actually place the bacterial suspension on it, if there is no bacterial growth there, then the test is invalid and cannot be interpreted. So the way it works, like I said, we prepare a bacterial suspension, and we compare the turbidity of this bacterial suspension to 0.5 McFadden standard, so that we would have a very standardized suspension that every single well will receive. We try here to provide a very fair playing field for all this, antimicrobial concentration into the wells. And then the plate will get incubated again, and then next day we read this plate. There are, automated ways for bacterial inoculation and reading these plates, which make the process more efficient and faster for the reading the susceptibility plates. And as we just discussed, this provides us with an MIC that we can use very, very carefully here to test for, to alter the dose or the concentration or the frequency of a specific antimicrobial that we need to use for treatment. So how do we read this plate? Like I said, we always look first. You probably see here, this is one of the plates that we use in the lab. It's the companion gram-negative panel for gram-negative bacteria from companion animals. And as you see here, the first thing we look for is the control wells, right? If there is no growth in the control wells, this plate is invalid and it has to be retested. And now we look for, the MIC will be the first well with no visible bacterial growth or billet in it. And for example, here you look for doxycycline. We have 0.5, the concentration is 0.5 microgram per mil, and then 1, and then 2 microgram per mil, and then at 4 microgram per mil, this is where no bacterial growth, and this is our MIC. Another example here for cefpidoxim, we have here, it start as 1 microgram per mil, and then 2 microgram per mil. Here was still bacterial growth in these two concentrations. At 4 microgram per mil, there is no visible growth. This is our MIC. And then you look here for chloramphenicol. Again, we have 4 microgram per mil, 2 microgram per mil, and then 4, 8 microgram per mil, and then 16. Right at 8 here, there's still a very tiny bacterial billet. That's still, bacterial growth there. So our MIC would be the 16 microgram per mil. Now, what happens if there is no growth at all in any of the concentrations, right? So if there is no growth in any concentration at all, from the lowest concentration to the highest concentration of the tested drug, the MIC will be lower than or equal to this lowest concentration, right? Which here for marbofloxacin will be equal to or less than 0.125 micrograms per mil. If there is growth in all the wells, right, from the lowest concentration to the highest concentration, then the MIC will be greater than this highest tested concentration, as we see here for cephalexin, right? There is growth up to 16 microgram per mil, which make the MIC here be greater than this 16. Same thing here for augmentin. We see the concentration is higher than 8 micrograms per mil. So then, we see that there is growth at the 8 micrograms per mil, which makes the MIC would be higher than 8 there. And usually, what we do recommend that any antimicrobial or any pathogen with an MIC that higher than the greatest tested concentration of this antimicrobial should not be recommended for therapy, simply because we don't know the end point. We don't know the MIC. For example, here for the cephalexin, the MIC could be 16.1 microgram per mil, but also it could be 16,000 microgram per mil, right? We don't know. We don't know the actual MIC here as we go. All right, so we talked about the MIC here. Why the MIC is important? Why do we care about the MIC? As I said, this allow us as veterinarians to calculate an appropriate dose and an appropriate dosing interval for our patients, right? We can come up with this dosing system. We can come up with as well the appropriate interval as well as we're gonna give a treatment course for our patients. It allow us to monitor the development of antimicrobial resistance over time, right? Let's say, a patient came to your clinic and with an ear infection. You send an ear swab to the bacteriology section at K-State VDL. We grow Pseudomonas aeruginosa from there. And for the drug X, the MIC was 1 microgram per mil, right? We use this drug, the dog is getting better. And then after a while, came back again with the same complaint. We collect another ear swab, send it to the bacteriology section. We grow the same Pseudomonas aeruginosa, but at this point, the MIC for this specific drug, for drug X, become 8 microgram per mil. Now there is, some level of resistance that this bug is building, and then, the MIC or the Broth microdilution allow us to monitor that. And then, of course, it allows us to develop this antibiograms, this overall antimicrobial susceptibility profile that our veterinarians receive from us in the report, right? Allow us to look into the bacterial response to different antimicrobials, and would benefit us that we can go with empiric therapy based upon the potency of these antimicrobials and the susceptibility of these bacterial isolates to them. All right, so we get to the fun part is, how we can actually use this data, right, to make a better antimicrobial selection choices right now when it comes to treatment. So I wanted to focus first here in this graph for 3 major definitions here. You see here in this table, or in this antibiogram here, you see those 3 different definitions. We have the test range, which is basically the lowest to the highest concentration or tested concentration of each drug in the susceptibility plate. We have the MIC, which is our lowest concentration at which this bacterial growth was inhibited. And then we have the interpretation. We have this judgment, right? The categorization of the organism, whether it is susceptible, whether it is going to be of intermediate susceptibility, resistant, or no interpretation, as we said, because we don't have the evidence, whether from in vivo data or clinical data or from in vitro data, to make this judgment. So for this example here, we have an animal came to our to your clinic, and then it was a nasty wound. We collected we collected a wound swab, a sterile wound swab from there. We send it to the bacteriology lab at K-State VDL, and we grew a Pseudomonas aeruginosa, and from which we decide to run antimicrobial susceptibility testing to see what antimicrobials here would be most suited for us for treatment. How we can make use of this data for better selection of treatment. First off, the antimicrobials with R interpretation or resistant interpretation should not be considered for therapy, simply because, as we said, R mean here that this specific bacterial isolate, the Pseudomonas aeruginosa here, will not be inhibited by the achievable drug concentration of this specific antimicrobial in the blood or in the target tissue. And the example here I'm using for us is the enrofloxacin, right? Enrofloxacin is R per the interpretation criteria, so we should not use this for treatment of this Pseudomonas aeruginosa. Antimicrobials with no interpretation or with NI, and the MIC is greater than the highest tested drug concentration, should also not be considered for therapy. And the reason here is because we do not what the MIC, we do not know what's the MIC, right? And the example I'm giving here is for doxycycline, right? It shows as NI, but the MIC is greater than 8, and the test range is from 0.25 to 8. So it's greater than the highest concentration of the doxycycline. This could be 8.1, could be 80,000 microgram per mil of doxycycline. We don't know. That's why, this specific option or this specific drug cannot be used at this point. Again, something as well, which is the antimicrobials that do not concentrate in the target tissue should not also be considered in therapy. And this is something I would love always to talk to our clinicians and veterinarians about as we talk, because, for example, tetracyclines in general, they don't concentrate very well in urine. That's not how their pharmacokinetics work. That's why we don't usually recommend them for treatment of UTIs. Nitrofurantoin, on the other hand, it's mainly concentrated and excreted in urine, and that's why it's not a suitable drug or antimicrobial for treatment in other tissues other than the urinary bladder. And then antimicrobials for which bacterium has intrinsic resistance should also not be considered for therapy. And this becomes very important here because we have certain bacterial organisms that we know that they have this weapons, they have this virulence mechanism that allow them to be multi-drug resistant to several classes of drugs, including, for example, Pseudomonas species. They are we know that they are have this intrinsic ability to become resistant to beta-lactam antibiotics, most of the beta-lactam antibiotics, and same for Salmonella species with aminoglycosides, Enterococcus species with most beta-lactams as well, and with potentiated sulfas like TMS. And the options I'm highlighting here is for this specific Pseudomonas aeruginosa from this wound are the beta-lactam antibiotics, right? You see, this is kind of a combination actually of 2 points together. It's a combination of here the MIC is greater than the highest concentration of the tested drug, but also the bacteria is intrinsically resistant to these beta-lactams. That's why, beta-lactams here in this specific case should not be used for treating this Pseudomonas aeruginosa. And then, if we take these factors all together and we try to filter out and narrow down the list of the antimicrobials that we're going to use for treatment or for consideration for treatment for this specific case, we come up with those options here, right? Those options based upon the in vitro susceptibility profile that we ran. Then we as veterinarians, we put all factors together. We think about, of course, like I said, the safety. How safe is this antimicrobial we're going to prescribe going to be for our patient? The ease of administration. Some of those options here are only available, as we all know, in injectable formulation. How easy it's going to be for administration. Cost, of course. Some of those options here as well are expensive antibiotics. So how is this going to be affordable for our clients? And of course, the target tissue involvement. If this specific antimicrobial will make it to the target tissue and allow it to kill the bacteria. We use then we know we get to know like which of those antibiotics is a time dependent antibiotic, which one of them is a concentration dependent antibiotic, and we look into the target serum concentration. And this is a topic I would love to talk to you guys about for sure. And I speak to our clinicians and veterinarians about it all the time. And maybe I actually can use this as an excuse to ask Dr. Hanzelchek to come back on the webinar for another time to discuss this with you in more depth. And then, of course, then we look into the pharmacokinetics and pharmacodynamics charts, and then we determine the dose and the frequency of the antimicrobial that is suitable for this treatment, or for this case for treatment. Then one thing also I wanted to highlight here, antimicrobials with resistant interpretation should not be considered for therapy. I know I said this first, but here, even if the MIC, the in vitro MIC, even if the in vitro MIC is less than or equal to the lowest concentration of the tested drug, if the interpretation is resistant, this antimicrobial should not be used for treatment. And here we're using this example about this Staph pseudointermedius was isolated from a urine sample right? We run susceptibility testing on it, and then as you see here, for example, for amoxiclav or amoxicillin clavulanic acid, the MIC is less than or equal to 0.25, which is the lowest concentration in the test range. However, it's marked as resistant. And the reason for that is this staph is amoxicillin resistant staph, which means that it actually carries a MIC-A gene, which make it, less susceptible to beta-lactam antibiotics and make those beta-lactam antibiotics ineffective as a treatment option. And then again, no interpretation does not mean that the drug is not going to be effective. And I'm also here picking on this example for this another sample, a purulent exudate from different sores in the neck and the legs of a patient came to the lab. We grew from it a staph simulans and strep canis, and again you see for amoxicillin clavulanic acid for streptococcus canis it shows as Ni. However, the MIC is less than or equal to 0.125. That does not mean that amoxicillin clavulanic acid will not work against this streptococcus isolate from this specific sample. It simply means that we don't have the in vitro and the in vivo data and the break points to make this judgment about the susceptibility profile. And then, of course, it's very important to highlight that for all our susceptibility testing that we share and we discuss with our clients, with our veterinarians, all those antimicrobial susceptibility testing, they come with this standardized comment that this is an in vitro testing, right? It's one of the very important tools that we use as veterinarians and as clinicians to determine which antibiotic we're going to actually use for treatment. However, other factors as well comes in this equation, including, of course, like I said, the ease of administration, the safety, the target tissue involvement, how this antimicrobial make it to the target tissue. Is it going to make it to the target tissue and kill this bacteria? And of course, the cost in there. With that, I would like to refer some of this is not a free ad here. It's actually just giving some credit for some of the sources that I'm sure most of our veterinarians and the clinicians use one or more of these, including, the Target Vet Antimicrobial app, very useful source for determining those pharmacokinetics and pharmacodynamics interactions, and good book for detection or for selection of dose dependent and concentration and time dependent antibiotics. Same thing apply for the First Line app, very nice as well app that provides you with similar information to the Target, and of course the Blum's Vet Drug Handbook. They have a very nice app as well that goes along with it. All these are very useful sources. Now, when it comes to certain bacterial organisms or fungal organisms where we don't have a lot of data, we usually go and dig in the primary literature for this, and then look into some of the data that has been discussed there, and we try to make an extrapolation from there. One example, is, we have, for example, breakpoints for Mannheimia hemolytica and for Bacillus maltosida from BRD cases, but against tularithromycin and most macrolides, and we don't have breakpoints for Piperistenia trihalosi. But since it is from the similar, from same animal species and a similar disease pattern, then we can make some extrapolation here. It merits this extrapolation coming from that type of analysis. Same thing for Ceftiofur, for example. We have breakpoints for Actinobacillus pylori, for strep suis in swine, but we don't have breakpoints for the Ceftiofur against Portodella bronchoseptica, for example, in pigs. And that's why, we can use, this is going to be very similar disease pattern, and we can make some extrapolation at this point. With that, I would like to say that we always love to hear from you, from all our clients, from all our veterinarians. We love always to get in touch with you. We are here to support you. We are here to answer all your questions. Please, if you have any questions related to sample collection, sending samples to the bacteriology lab, antimicrobial susceptibility interpretation, please feel free to reach out to us at these contact information. And with that, I'm very thankful for all of you for being here this afternoon. And thank you, Dr. Hanzelchik, again for inviting me, and I will take any questions.
Thank you, Adam. This subject was always a little bit of a black box for me when I was in practice, and I understand it a lot better today. Do I understand it completely? No. So if I was still in practice, I would guarantee you I'd be calling you to pick your brain in certain cases. And again, Adam really likes to talk to practitioners, so please pick up the phone, email him, whatever you need to do to better manage your cases. We've got some questions in the from some participants. How do you check turbidity? Is it visual or done mechanically?
The turbidity in the plates.
Mm-hmm.
We actually this is a very good question. We check this by mechanically. So we look into the plate, and if there is and there is a camera in the automated system, we'll actually look into the bottom, the back side of the plate, and show you this turbidity, or show you the billet, the precipitation of the bacterial growth. If we have a well that we are not very sure about it, we get the plate out of the machine, we hold it up against the light, and make sure that what we're seeing is turbidity, or a bacterial billet, or this is just the suspension itself.
Very good. So we report out MICs.
Correct.
Would there be any benefit to report out MBCs?
That's a very good question. It would be, like I said, especially for immunocompromised patients, those patients that their immune system is already not good enough. We need to get to the MBC as better as we can get, and stay at this level, so to have better protection for those patients. Like I said, MBC is this kind of the threshold, which the development, the selective development of mutants become very rare, and it's usually at 10x of the MIC. So if the MIC is 1, then we could always make in our mind this is going to be 10x of the MIC. However, like I said, it's not always achievable in the serum of the animal, because we are capped with the dose we use, and the serum concentration we can get, or the target tissue concentration we can get.
Very good. Another question is, you said that you update the information, the breakpoints. How often is that done? Where does the data come from?
Right.
Yeah, I guess that's the question.
Sure. This is a very important question as well. These breakpoints always come to us through CLSI, through the Clinical Laboratory Standard Institute. When they publish these data, they usually publish it every 2 to 3 years, sometimes 4 years, based upon when we have more data available. If the data is available sooner than that, and more more immersion data is available, then we make a newer revision earlier than this. Once these are available, they are published in a printed document. But also, the pharmaceutical company, or the laboratory providers companies for these antimicrobial susceptibility plates, or these automated systems, become aware of it. They also programmed it in their softwares and upload it to our system as soon as they are published.
Another question is, we don't report out susceptibilities for mycoplasmas. Why is that?
Correct. This is very important as well, because we do not run mycoplasma susceptibility. Mycoplasma, as most of our, as all our clinicians know, very slow growing organism, right? It requires, minimum of 5 to 7 days to grow, and this is if we have a very good population of mycoplasma in the tissue, and we have fast growing mycoplasma like Mycoplasma bovis. Certain mycoplasmas are slow growers, and it takes them a couple of weeks, maybe actually several weeks, to grow. And you could imagine now, if we have this mycoplasma in a susceptibility plate and incubate this plate for 7 or more days, this is gonna, affect the concentration of this antibiotic in the well and skew the results. That's why we don't have a very well standardized technique so far in most of the diagnostic labs, I would say, for mycoplasma testing. I know some private companies, at least one or two in the country, they are running mycoplasma for small animals like Mycoplasma sinus, and I would be happy to connect our clients with those vendors if they need to.
Okay. We have time for one question, and the question is, do you perform MBD manually, or do you use commercial BMD plates?
I'm sorry, what was the question again?
Do you perform BMD manually, or do you use commercial BMD plates?
We use commercial plates.
Okay.
Yeah, we use commercial plates for all our testings.
And I think we have one more question here that we have time to answer. So KSVDL in the past did not offer anaerobic susceptibilities, but now since you've taken over a section in, I don't want to put you on the spot, but why are we now offering? What is the value of that?
I think it becomes very valuable for us, especially with certain anaerobic bacteria that, again, we don't have a very well predictable antibiotic profile for them, especially like Clostridium species, right? We have recently, for the last few weeks or several weeks, actually, we got a lot of Clostridium perfringens type E being isolated from several outbreaks, or several cases in Kansas, and becomes very important for us to look into their profile, see what they are susceptible to, and what antimicrobial that they are resistant to. Usually, like certain anaerobic bacteria have a very predictable susceptibility profile, like some bacteroides species. However, others, especially Clostridium species and Diclobacter species, those become more difficult to predict, and becomes more valuable for us to know their profile, their antimicrobial susceptibility profile, and what drugs are more appropriate for treatment.
Very good. Thank you all again for joining us today. Thank you, Dr. Katana, for providing an outstanding presentation. And look for us to be emailing you about our next webinar. It will be scheduled for August. I'm not sure what the topic will be, but we'll be sending out some notices here before long. So thank you all again for joining us, and have a good day, and have a good Independence Day next week.